So good morning, everyone. I'm happy to see you back with me after some of you being away for, given the task or posted in the COVID-19 board, and especially with Dwi. Everyone miss you, Dwi. Especially Dita. Dita was crying a bit because she didn't see you yesterday. But I believe we are all happy to see Dita is happy to see you through this platform. And also for Reynard, hopefully that he's okay to join the room, but he is welcome to leave the room anytime for being unwell. Now let's start with the session for today, which is quite unique. We start the sessions with reviewing a video on public education. So you are given the task to connect the points in the public educations, in the video with any potential evidence-based medicine that could support the content in the video, and we learn something from the evidence and also elaborate on how we may correct or revise the points in the public educations. In the video, if possible, but if not, at least we take lesson and then we see the readings based on the evidence. So you are all welcome, whoever is ready now with the presentations, and others would be the discussants. The opponents or the proponents to discuss the topic that someone is presenting. All right?
Okay. May I share my screen, Doctor?
Yes, you're welcome to share your screen. The waiting, I purposefully using my virtual background with teaching initiations because this is the platform that I created to innovate myself and share the ideas to the public with the initiations in terms of teaching. Hopefully you could see. I think if any of you have already seen any video in my channel, then you may have seen this example on the teaching initiation.
You can see my screen, Doctor?
Yes, very clear.
Okay.
Halo, beberapa lama kita tidak bertemu ya. Senang sekali bahwa saya memiliki kesempatan pada sore yang mendung dan sedikit redup pada kesempatan kali ini. Kebetulan saya punya waktu untuk bisa bertemu dengan Anda. Saya akan mengawali apa yang akan saya bahas pada kesempatan kali ini dengan memberikan pujian. Memberikan pujian adalah bagian pemberian umpan balik, feedback dalam keseharian kita berelasi, berkomunikasi. Dan biasanya yang paling mudah kita bisa gunakan gestur atau menggunakan emoticon kalau sedang bervirtual ya. Jempol. Iya. Mengangkat jempol untuk memberikan pujian bagus, hebat, dan sebagainya. Ternyata bisa kita beri pengamatan tersendiri oleh karena ada peran tendon di sana. Bisa Anda lihat ya, ada cekungan dan kemudian ada kabel tendon yang tegas, 2 buah, tetapi saya akan menyasar bagian yang paling tepi dari tendon Anda ini. Bagian ini bisa mengalami nyeri. Banyak di antara Anda yang sudah pernah membaca dan mengetahui. Ya, saya akan berbicara sedikit tentang di core vein, yaitu kondisi sakit yang disebabkan oleh radang, inflamasi pada bungkus tendon untuk mengangkat ibu jari seperti yang saya tunjukkan yang sangat nyata ini. Bungkus tendon itu layaknya adalah selongsong yang mengalami peradangan, merah kalau biasa dilihat meradang di permukaan kulit, Sementara yang ada ini adalah selongsong tendon itu sakit. Dan kalau berjalan lebih lama akan nyata dengan terjadinya pembengkakan yang lalu membuat selongsong itu menjadi tebal. Apa akibatnya? Akibatnya adalah tendon yang harusnya meluncur, bergerak maju mundur untuk membantu pergerakan jempol ini menjadi terhambat, terhalang oleh karena selongsongnya kalau dilewati oleh tendonnya yang bergerak menjadi nyeri, sakit, aduh, benar-benar sangat mengganggu. Bagaimana itu bisa terjadi? Ada banyak kejadian dalam keseharian kita yang tidak kita sadari, kita kerjakan secara berulang dan membebani ibu jari kita atau jempol kita ini. Saya bisa ambil contoh misalnya pada pekerjaan kantor. Kita tahu ya, di masa yang lalu banyak pekerjaan menggunakan kertas. Sekarang juga mungkin pemberkasan dengan dokumen menggunakan kertas. Nah, contoh aksi yang bisa memberikan beban pada ibu jari adalah waktu kita mengerjakan stapling. Menggunakan alat, menekan stapler menggunakan jempol berulang kali. Dan tanpa disadari, bagian tendon ini, jempol ini, di bagian pangkal ibu jari ini, mengalami beban yang berlebihan dan berulang kali. Contoh yang lain barangkali dalam kehidupan sehari-hari di rumah ya, adalah urusan mengurus pekerjaan rumah, misalnya mengepel lantai, atau mencuci baju. Kita bayangkan ya, untuk mencuci baju secara tradisional, kita terbiasa harus memeras cucian. Waktu memeras cucian, nah ada gerakan melintir pada pergelangan tangan yang juga disertai dengan kekuatan genggam yang memberikan beban kepada jempol, lalu jempol, tendon yang menggerakkan jempol ini atau ibu jari ini mengalami pengulangan cedera. Yang lain lagi barangkali sama ya, urusan mengepel lantai. Jadi membutuhkan tenaga putar begitu. Ya, dalam pekerjaan heavy duty atau yang membutuhkan konsep pertukangan gitu, screwing and unscrewing, ya, memutar baut dengan menggunakan obeng, dan juga banyak contoh-contoh yang lain, termasuk diantaranya adalah posisi yang tidak diharapkan membebani kondisi tendon pada ibu jari ini secara berlebihan ketika kita melakukan aksi yang memberikan gaya yang besar. Termasuk juga pada olahragawan. Jadi bagaimana? Mau urusan kantor, mau urusan rumah, mau berolahraga. Ya sayangnya memang banyak kejadian tidak dapat dihindari karena itu merupakan keseharian kita. Lalu apa yang harus dilakukan? Sebelum saya bicara dengan apa yang harus dilakukan, khususnya tentang pencegahan, maka saya akan mengajak Bapak Ibu untuk mengetahui bagaimana mendeteksi decor vein secara sederhana.
Okay, Doctor, I will continue with my presentation, Doctor. So, thank you, Doctor, for this great opportunity to present about the decurvain tenosynovitis. So, from the video, we can see that you already mentioned about the definition, and then the sign on symptoms, and then the etiology of the decurvain syndrome that I will explain later in my presentation. So, first, the definition. The decurvain is a stenosing tendinopathy involving the first dorsal extensor compartment. So, as we know that the decurvain is a Swiss surgeon. Here's the photo of the decurvain. 1895, he found the decurvain tenosynovitis. Dr. Decurvain is a surgeon, and he is famous for the invention in thyroiditis and for the tenosynovitis. So as we see, the first compartment that affected by the tenosynovitis is the first compartment, and it consists of abductor pollicis longus and extensor pollicis brevis. So this is the anatomy of the compartment. So we have 6 compartments, but we only this disease affect the first compartment, that is APL and EPB tendon. And then if we see in the surface anatomy, so we can see that two of the muscle and tendon affects the movement of the thumb. So the function of the APL and EPB are to abduct the thumb at the carpometacarpal joint, and then the EPB will extend the thumb at the MCP joint. And APL often has several tendinous slips, and the EPB can travel through its own separate subsheet. So this is what it causes tenosynovitis. And then the epidemiology is it usually appears in the 5th and 6th decade of life, and women is more frequent than men, 6 times more frequent than men, and then it caused by repetitive motion. For example, household works. Many repetitive use of thumb, such as pinching or typing, it can be also as a risk factor for the curvain tenosynovitis. Also, lifting heavy objects or doing the heavy duty works. And then this is more frequent in pregnant and lactating women. So for this reason, why pregnant and lactating women experience more tenosynovitis, it is still debatable. It is affected by hormonal changes like progesterone or estrogen increase, or because of the repetitive motion, because pregnant and lactating women are always busy, so they can do the repetitive motions to take care of the baby. Next, I would explain about the pathophysiology. So the pathophysiology of the curvain tenosynovitis is because of the repetitive motion of the APL and EPB within compartment, and it makes the frictional force. The frictional force will cause swelling and thickening of the retinaculum, and then it will narrow the tunnel and pain with the motion. So if we see in the histopathologic examination, it shows that it's lacks of a inflammation reaction, but they show the myxoid degeneration within a thickened tendon sheet. A gradual onset of a radial wrist pain and tenderness to palpation over the radial styloid is a pathognomonic of this tenosynovitis, and it is exacerbated by ulnar deviation of the wrist and thumb adduction. This is the example of the movement that can cause the pain in the curvain tenosynovitis. Before I continue to the physical examination, maybe I will continue with your videos first, doctor.
Okay, good. You may proceed. Dita and Reynard, be ready with the discussions. If you have different angle and also maybe with different references later on after Dwi finish with his presentations.
Permission to continue, dokter, with your video.
Pada dasarnya kita bisa memberikan beban pada tendon ibu jari ini dengan meletakkan ibu jari dalam telapak tangan, di bagian telapak tangan, lalu dalam genggaman jari-jari yang lain, kemudian pergelangan tangan dibengkokkan ke arah kelingking. Jadi tendon ini akan berada pada ketegangan yang maksimum. Maka kalau Anda mengalami nyeri, Anda berbakat atau sudah mengalami decurvein. Ya, urusan nyeri memang bisa banyak sebabnya, tidak hanya yang berasal dari tendon ini. Kalau kita berbicara soal ibu jari ya, bisa juga berasal dari persendian, dan juga struktur yang lain. Kebiasaan misalnya mengangkat tali atau ransel ya, tali pegangan tas, ransel tas punggung kita yang berat, lalu memberikan beban pada ibu jari, ini juga bisa memberikan cedera pada ibu jari. Tetapi model cedera itu tidak sama dengan the core vein, bisa saja cedera itu berada pada sendinya. Saya kembali pada the core vein. Lalu bagaimana mengatasinya? Ya, saya harus akui sulit untuk mengatasi bagaimana mencegah cedera pada ibu jari kita. Padahal banyak sekali pekerjaan yang tidak mungkin tidak kita kerjakan dengan menggunakan ibu jari. Apapun itu, inti yang perlu kita carikan jalan keluarnya melalui kesadaran untuk mengurangi beban pada ibu jari ini adalah mengubah gaya. Jadi kalau saya ambil contoh misalnya stapling tadi ya, tekanan kuat pada stapler pada waktu mau stapling, memberikan jepitan pada dokumen misalnya, tidak kita kerjakan dengan pembebanan ibu jari, melainkan bisa kita lakukan dengan menggunakan telapak tangan yang menekan stapler itu dan bisa memberikan efek clipping pada dokumen. Bagaimana dengan mencuci? Ya, jawaban anak sekarang gampang. Tentu saja pakai mesin cuci. Beres, tidak ada beban lagi pada perasan pakaian. Begitu pula dengan urusan mengepel lantai misalnya. Pakai saja ya alat untuk mengepel yang komersial tersedia di toko, di mall, di supermarket, atau bahkan di pasar. Untuk memudahkan kita dalam bekerja, maka alat pel itu bisa dibantu teknik perasnya dengan alat komersial yang tersedia di pasar. Nah, yang lain semuanya dapat dimodifikasi dengan cara mengurangi beban pada ibu jari. Bagaimana dengan kalau sudah terjadi nyeri? Ya, nyeri itu antara lain adalah panggilan, peringatan kepada kita, sang pemilik ibu jari, untuk meminta kita memberi perhatian dan mengistirahatkan ibu jari. Istirahat ibu jari jangan banyak digunakan. Nah, tentu saja yang paling mudah memang datang meminta pertolongan medis, sehingga bisa dibantu dengan penyangga atau bidai atau bebat yang membuat gerakan ibu jari itu tidak bisa banyak. Barangkali gerakannya relatif minimal. Sementara kalau dijaga untuk tidak terbebani banyak, sebetulnya kita masih bisa menggunakan secara ringan, oleh karena ibu jari ini masih bisa bertemu dengan jari-jari yang lain gitu. Nah, pengobatan yang lain tentu saja untuk yang sudah lanjut bisa disertai dengan intervensi, memberikan suntikan, atau juga bahkan dengan operasi. Saya masih ingat salah satu anak teman ya, yang begitu aktif, dinamis, menjadi sangat tersiksa karena aktivitasnya sangat terganggu. Bahkan hanya untuk pekerjaan kantor, typing, mengetik, menjadi sangat terganggu karena ibu jari ini yang terhalang aktivitasnya akibat nyeri. Lalu pertolongan yang kalau sudah dilakukan secara non-bedah tidak berhasil, maka perlu dilakukan pembedahan. Pembedahan pada dasarnya dengan membuat sayatan kecil saja, ya, untuk bisa memberi ruang pada dokter bedah, khususnya dokter bedah tangan, dokter bedah plastik, dokter bedah tulang ya, untuk bisa memotong selongsong yang sudah kaku menebal itu. Jadi kalau selongsong tendon itu sudah dibuka, maka jeratan pada tendon menjadi berkurang, bahkan hilang, dan tidak ada lagi sensasi nyeri. Tentu setelah melewati fase waktu untuk sembuh. Dan si dia ini bisa bahkan berkickboxing tanpa ada gangguan lagi. Jadi Bapak Ibu sekalian, kalau toh kehidupan sehari-hari kita tidak dapat kita hindari secara optimal untuk mengurangi atau menghindarkan pembebanan pada ibu jari, tidak usah khawatir. Mudah-mudahan tidak sampai, tetapi kalau toh harus diperlukan, maka pembedahan yang relatif tidak mayor, minor saja, operasi sambil bernyanyi, selesai operasi bisa pulang, dapat menolong Anda sekalian. Kita bertemu pada kesempatan berikutnya. Jangan lupa, jaga kesehatan.
Okay, doctor, I will continue with my presentation, doctor.
Yes, please.
So back to my previous slide before. So this is the motion that Dr. Teddy has already explained in the video about how to diagnose what movement will cause the tenosynovitis. If you feel pain in this motion, so you are at risk or you are already tenosynovitis decurvain. So this is the example of the hand movement, but we have the physical examination for this tenosynovitis. The first one, we can ask the patient whether he or she has tenderness over the first dorsal compartment at the level of radial styloid, and we palpate it, and they feel pain. Usually, if you have the decurvain tenosynovitis, the normal wrist motion is normal, but pain resisted with radial deviation. So if they use the ulnar deviation, so he or she will feel pain, but it will resist it by radial deviation movement. So we have, according to the journal that I read, there are three provocative tests for diagnosing this decurvain tenosynovitis. The first one is a Finkelstein test. So the physician or the doctor is holding thumb while hands force into the ulnar deviation. On the grasping patient's thumb and quickly abducting the hand ulnar ward, the pain over the tip styloid tip is painful. So it will diagnose the tenosynovitis with this maneuver. And the second maneuver is a Hoff test. So this is the maneuver of the Hoff test. So we grasp the thumb in palm of hand whilst the wrist is ulna deviated, and then the relief of pain was relieved once the thumb is extended, even if the wrist remains ulnar deviated. Maybe in some textbook I didn't find this, but I found in this journal, orthopedic journal, about the wrist hyperflexion and abduction of the thumb test, or they call it Watt test. So this is the maneuver of Watt test, modification of a Finkelstein test. So it is an active testing by shearing the tendons of the first extensor compartment against the palmar distal edge of the pulley. So the Watt test performed as follows. The wrist was hyperflexed and the thumb is abducted in full MP and IP extension and resisted against the examiner's index finger like this. So this is the three physical examination or the provocative test to diagnose the tenosynovitis. How about the non-surgical treatment and the surgical treatment? So prevention is the best medication. But every work we do every day, we use our thumb. To avoid the tenosynovitis, we can do something like Dr. Teddy's video before, such as the modification of a lifestyle. So, for example, we reduce the work of our thumb or fingers, such as you can you do the stapling with your palm, and then you can wash your clothes with washing machine, or do the mopping with the commercial tools that are sold in the supermarket, malls, or in the department store. So this is the treatment if you are already have symptoms. The first one, the most simple and inexpensive way of the non-surgical treatment is rest. And then the second is the non-steroidal anti-inflammatory medication. So this is the second simplest method to alleviate the pain. And then the third, we can do the spleen immobilization. For example, we can use thumb spica with the position of thumb flexion 30 degrees and abduction 30 degrees. This is the example of the thumb spica, and many more brands we have. And then the last is corticosteroid injection. So corticosteroid injection, we use for in this journal they use 40 milligrams of methylprednisolone mixed with 1 cc of lidocaine 2% to inject. Okay, this is the example. Corticosteroid injection may cause some complication, but it is rare. The possible complication of corticosteroid injection may cause the fat atrophy, discoloration of skin, and in a rare circumstance, it can cause the tendon rupture, but it is very rare. And then the last thing about this is the surgical treatment. Surgical release of the tendon was done because the symptoms persist after non-surgical treatment. So if we already perform the non-surgical treatment such as resting, and then we use oral non-steroidal anti-inflammatory drugs, we use the splinting or the corticosteroid, or we use the multimodality such as they do the corticosteroid injection and also the splinting, or the symptoms is not alleviated, so we can use the surgical release. So this is the video that I got from YouTube from the University of Washington Hand Center. This is about how we do the surgical release. So it is a simple procedure. It doesn't take a long time, and the patient could not in general anesthesia. They can be in local anesthesia only, and the patient could go home directly after the surgery.
Surgery for decoveinous tenosynovitis. This is a stenosing tenosynovitis, the first dorsal compartment. An incision is made at the distal aspect of the compartment in order to provide the best visualization of the tendons and the compartment that needs to be released. The soft tissue is carefully mobilized in order to protect small sensory branches of the radial sensory nerve. In this case, the two components are identified with the APL and EPB having separate compartments. Once the soft tissue is carefully mobilized, the first component with the APL compartment is released under direct vision with sternotomy scissors. There's a second compartment, in this case for the EPB, which is also released. There's a tremendous amount of synovitis surrounding the tendons that is removed with sternotomy scissors in order to be able to better inspect the tendons to ensure that there are no additional compartments that need to be released. Once this is completely released and stabilized, the wound margin injected with 0.25% marking with epinephrine, the wound is closed with the runnings of cuticular suture. Patient splinted for 2 weeks in a plaster thumb spica splint.
Okay, so we do the transverse or longitudinal incision of the first dorsal compartment, and then we have to protect the radial sensory nerve because we don't want to have a complication because of the radial sensory nerve. And the first dorsal compartment is sharply divided on its dorsal aspect to prevent the polar subluxation of the tendons. And then the compartment must be closely inspected for the presence of the EPB subsheet. And then the EPB should be clearly identified and passively tested to ensure the thumb metacarpal extension before the surgical release is complete. Because if the surgical release is not complete, and there will be a relapse. The failure of the subsheet at the time of surgery is potential cause of the failure of the surgical release. And how about the complication of this surgical treatment? the possible complications are failure to decompress with recurrence. So the main key points is the release of the EPB, like I mentioned before, and in the video. The second is injury to the branches of the radial sensory nerve. So after we open the compartment, we should be aware of the radial sensory nerve because it can cause the symptomatic neuroma, and also it can cause this volar subluxation of the APL and EPB tendons after the first dorsal compartment release. These are my references for this session, doctor. Thank you, doctor.
Great. So Dwi, congratulations. I'm so happy to know this initiations is responded well, at least by your presentations. You could pick the points that are important for you to learn and also to share it with the others, because the other residents are also ready with the topics and they might discover different points, or even though you could discuss the similar aspect that you end up with your finding, but it would be good to welcome you with a different angle of topics to discuss. Now it's open for discussion. Dita and Reynard, you are welcome to discuss.
Thank you, Doctor. Thank you, and also thank you, Dwi, for the presentation. Maybe I would like to add some points about the physical examination that I already read before in the other article. That is for the physical examination of the quad vein tenosynovitis. Yes, there are many physical examinations, like Dwi said on his presentation, but mostly it makes the patients feel pain. So from what I read, there is also one physical examination that maybe we can use this first before the other physical examination, that is the tethered thumb sign, which is we have didn't feel pain by doing these examinations. The examination is we did examination on both of the patient's hands, and then we did the ulnar wrist deviations by letting the thumb free. So when we did the ulnar deviations, we see the thumb, whether the thumb is going to the ulnar side also when we did the ulnar deviation, or the thumb is remain aligned with the forearm. On the quad vein tenosynovitis, in the thumb that will affected by this tenosynovitis will remains aligned with the forearm, because she or he will feel pain when they move his finger, move his wrist on the ulnar deviation, doctor.
The main intention that Dita presented was about the less provocative examinations, because with the Finkelstein, it's quite provocative, and I believe in the chronic situations, patients would feel pain before you completely perform your Finkelstein examinations. What Dita mentioned is to try to free the thumb in its positions accordingly by the feeling of the patients, while we force the wrist into ulnar deviations. Is that so, Dita?
Yes, doctor. Thank you for
Okay, very short compared to your lengthy explanations. All right, Reynard, do you have any other points? Not necessarily to be the topic on the physical exam.
Yes, doctor. I just want to add a little bit about the the process of the disease itself, although the name is it is named as decurvain tendinosynovitis, but it is actually a bit misleading that I read, because the process is actually a nutritional or like a wearing down because of stress process and degenerative process. This is shown by the histological examination, where the findings are deposition of fibrous tissue, increased vascularity of the tendon sheath, and accumulation of mucopolysaccharides. That shows that this is a process of myxoid degeneration that also Dr. Dwi has explained in his slide before. The synovial linings were shown to be histologically normal, so there is actually not any signs of actual inflammation, doctor. Thank you.
Right, thank you. So, Dwi, you could add more, but I just want to underline what Reynard just mentions. It would be good for Reynard to type the reference in the chat box so that Dwi and also Dita could detect the reference that you used. And also, Dita, you could put the reference in the chat box so that Dwi and Reynard could take your reference with the physical exam that we discussed. So, the case that I picked in the video, which is educational video for public about the corvain tenosynovitis, was about the young patients, which is different with the textbook that you presented. This tenosynovitis presents mostly or occurs mostly in the second or fifth decade. So this is quite interesting, where the cause is not only about degenerative disease like Reinhard has mentioned, but also about repetitive motion. So it's not really exact hypothesis on how this tenosynovitis, how this inflammatory disease takes place. It's like combinations of hypotheses. Dwi.
Okay, doctor, thank you for the response. As I mentioned before, the risk factors of the tenosynovitis are many things, but often occurs in the fifth or the sixth decades of life, but it is possible to be happen at the productive age life. So, for example, I already mentioned about the repetitive motion of household works, or you can or in your video you said that the heavy duty works. And then I read in some journal that the pregnant and lactating women are also prone to have the corvain tenosynovitis. And then the pathophysiology is still debatable about the elevation of level of progesterone or an estrogen, or and also the stress or the mechanical friction that was caused by the repetitive motion. So I think maybe this disease can occur in every age, not only for the old age, but also in the productive age, in the young age, because of the pathophysiology of the disease, doctor. Thank you, doctor.
Thank you. You are right, Reynard and also Dwi. In the video, it was not shown that the disease may take place also in pregnant women. This is quite interesting because it's quite unique. Once after the woman delivered the baby, the disease gradually healed. That's very interesting. One hypothesis mentioned that this may the chance for mother with new baby to lift up the baby repetitively on daily basis. And you could imagine how many times the mother would lift the baby up for many times in a day with her non-dominant hand lifting up the neck and also the head of the baby. That's an example as the cause of repetitive motion to create inflammations in this first compartment of the extensor tendon. On the other hand, the mother during pregnancy got the problem, even though she hasn't got the baby yet. So it's also kind of like mixed combinations of hypotheses in between the role of hormones, I mean, yeah, the endocrine related cause and also with the actions or repetitive motion. With the case that I presented, it's a very active lady, young lady who works at office. So maybe computer is also play role. While Dwi present at his presentations, he showed that typing with cell phone is also a factor that may cause this tenosynovitis. Could you elaborate a bit about the texting?
Okay, doctor. Because texting use all the use the thumb, the bilateral or the unilateral thumb. So maybe for the repetitive thumb, and then some people are typing with power. So maybe it is like the risk factor to develop the tenosynovitis because of that risk factor, doctor.
Okay, so what would you advise to the public if they get a pain while texting?
So for example, maybe the lifestyle modification, doctor, the first thing. So the typing properly, not too hard, but we can use soft, or we can educate the patient to adjust the sensitivity of the touchpad, I think, doctor, because uh, in some patient, maybe if they have a thick screen protector, they have to be uh, powerful in texting. So maybe that's the part of the modification, doctor.
Okay, so they need to push harder.
Yes.
The other modification, good point, Dwi, but you may add in your what do you call education to public is to modify the way of texting by using index. So it may be slower while texting, but it protect your thumb. On the other way of protecting your thumb while having pain because of this texting, this is part of our modern life or this current way of life, then they need to put the thumb on splint so that the thumb would be reduced in terms of the stress actions to the first compartment in the wrist level, although they still use the thumb to text. But the motion of the thumb would be reduced. But this is not better than changing the behavior using index or change the gadget. At least, as you mentioned, change the protector of the screen, I mean the screen protector, so that it would be lighter for the person to push the keypad or the screen in their gadget. That's good. All right. Back to you, Dita, if you have any other points to discuss. Yeah, it's good to see that the three of you posted the references so that you could share each other.
Actually, may I have one question to the doctor?
Oh, yes, please.
I would like to ask about until what time that we did the non-surgical procedure or treatment of the patient. I mean, until what time we did the rest position and then splinting or the injection of the steroid injection to the patient.
Yes, Dwi.
Okay, thank you, Dita, for the question. I would like to try to answer about this. So the non-surgical management is depends on the patient's problem. So if they already feel okay about the treatment, then they will continue. But if they are feeling uh, if he or she bothered by the sign or symptoms, so he or she will seek for the another more advanced technique for the disease. So, for example, for the resting, the exact time when to rest or when to start the thumb exercise, and then So I think the rest is maybe depends on the patient also. So if he or she does the work like maybe 3 or 4 hours a day, so they can have a rest like maybe 3 or 4 hours also, and depends on the sign on and the symptoms of the patient. And then for the medication, so it depends on the level of pain. And then for the splinting, I read the splinting is performed for 2 weeks. 2 weeks. So if the patient is not operated or having a surgery, so it is 2 weeks. But if the patient after the surgery, they can have a splint for 2 weeks also. And then for the corticosteroid injection, they can repeat it every 4 to 6 weeks. There is any pain, then they can repeat it again, and they can repeat again. Maybe any correction from Dr. Teddy? Thank you, doctor.
Okay, good. You have elaborated all the possible conservative treatment to respond to Dita's questions. But I would like to highlight about the resting positions for how long you would advise your patients to get rest of the thumb. So it's during the acute phase, I mean acute pain, then it's better not to use thumb at all. So the thumb would be rest fully. It would be better to put the splint for the patients. It may be the soft splint, like one of the example in your presentations, or with the hard splint. It's going to be good for providing full rest for the thumb. But if it comes into chronic already, then reduce the activity or thumb motion would be the main idea. So the least possible they use the thumb, the better the outcome. If it is still in the corridor of conservative treatment, there is no cut-off point for how long we would wait or we should wait, because it depends on the response from any patients. I mean, different from patient to patients. When the patient does not take the level of pain, then they would usually come faster for surgery compared to others who could, take the pain and they live with it for much longer. But after 3 to 6 months and even longer, you could not expect that the problem with the tendinosinusitis would relieved. So then surgery is an indication. In regards of the injection, it's quite interesting. I would welcome anyone to respond where to inject. And the exact volume that Dwi was presenting was not clear. So you are welcome to respond, any one of you.
Yes, doctor. With from the reference that I read, the point of injection should be between the APL and EPB tendon, but not to inject onto the tendon itself. And for the injection, as Dr. Dwi said, it could be with 40 milligrams of methylprednisolone with 1 cc of lidocaine 2% in the first dorsal compartment at the point of maximal tenderness in the in that area, doctor. And also, I read that the injection should be aimed proximally towards the radial styloid, doctor. Thank you.
Okay, a good point. So just want to clarify your last statement. You mentioned that the injections is toward proximally and it's toward the radial styloid.
Yes, doctor.
Do you understand the meaning of that terms? I mean that phrase?
Yes, doctor. So from the technique, it means that we inject towards proximally towards the forearm, and we inject with an angle that points the tip of the injection towards the radial styloid, doctor.
Okay, good. Any other?
Maybe I would like to add information according to Reinhard said, Doctor.
Yes.
Yes, I would explain about the doses of the injection. So, in the journal I read, it's about they use the methylprednisolone acetate, 40 milligrams, 1 cc with 1 cc lidocaine 2%. So they use 3 cc syringe, but they change the needle into the 1 cc needle, 25 or 22 gauge, 27 gauge. So the patient will feel less pain because of the small needle. Maybe I will add about that, doctor. Thank you.
Thank you. Okay, Tita, would you do the same?
Yes, doctor, from the article that I read before, it is the same thing with Reinhardt explanations. We use the 40 milligrams of methylprednisolone with 1 cc lidocaine, 2%, in the first dorsal compartment between the APL and also the EPB. Yes, like
Okay.
that.
All right, good. So do you have any other points to discuss? If not, then I would like to have your explanations further in regards of the surgery. So you may not questions the incisions and where to incise, but the question addressed to which point that you need to cut. Dewey has clarified that in his presentations, but maybe I would invite Reinhard and Dita just to make sure that you understand which part is actually the structure that you cut. Dita, Reinhard?
Yes, doctor. So my readings were similar to what Dr. Dewey presented earlier. If I try to explain it again, the incision was done at the point of the above the over the radial styloid, and then Dr. Dewey mentioned that it was a transverse incision, but I also read it could be an oblique incision, and then the skin is retracted and blunt dissection, and be careful to protect the radial sensory nerve in the subcutaneous tissue. And then after we found the extensor retinaculum, we tried to release the first dorsal compartment along its dorsal border, if I'm not wrong, what Dr. Dewey said earlier, revealing the APL and EPB tendons underneath, doctor. Thank you.
Okay, good. Do you agree that the statement that Reinhard mentioned is what you cut is the extensor retinaculum at the first compartment?
Yes, doctor.
Okay. Dita, do you get the same?
Yes, doctor. Yes, doctor, on the extensor retinaculum, doctor.
Okay, so if you see the video that we presented, it looks that the hand is clearly pale. Do you think that the video, I mean the surgeons in the video use tourniquet?
I think so, doctor, because it is generalized pale, not localized pales like we see in your surgery with tumescent, doctor.
Okay, now it's for our chief resident. If it were in your hand, would you perform the surgery under tourniquet or with fully awake hand surgery using tumescent injection?
I think I prefer to do it on the fully awake hand surgery, doctor, because it is a local incision and local incision of the dorsal side of the wrist, the extensor retinaculum, and I think it is not need to use the general anesthesia and also the tourniquet, doctor.
Okay, it does not necessary to use tourniquet, and of course we are away from general anesthesia, but both techniques with tourniquet or totally without tourniquet by embracing the Tumesen technique is just welcome because the procedure would be quite short. So the patient may bear the ischemia for several minutes, but make sure that you do fast. So then, if you are in your first practice performing this decore vein release, then I would welcome you to embark into the tumescent injections rather than putting tourniquet because you feel like you are limited by time. Generally speaking, individuals may stand for maximum 18 minutes. So roughly in between 10 to 15 minutes, they start to complain pain with ischemia by applying tourniquet. So you are going to be feeling more freedom. I mean, having more freedom if you embark into the tumescent injections. So just a short sharing, just to make sure that if we look into the incisions, we could see from this video, this is the video of my patient, that the scar, oh, it's not really that clear, but the scar is very small. This video is sent by her. You see the scar? Yeah, very short scar. And it's quite good also to know that she performed very well with this sport activity. Meaning that we do not see that she has a limitations with the actions of performing boxing. It's fully recovered. Okay, so thank you very much, Dwi, Dita, and Reynard. But before I end these sessions, I would welcome you to give your experience on the way of these learning modifications by reviewing a video on public educations, and then you embark into finding the EBM and try to structuralize the informations scientifically so that you could add also some points that were not exist in the video, and you could learn more rather than only seeing the video. Besides, I understand the intentions of these initiations is also to provide you observing the way you translate your scientific understanding into the lay language when you explain the problems in medicine to the public. So I welcome any comment or feedback with this learning experience.
Yes, thank you, doctor. From this experience, I think it would make us easier to learn some topics by using the video as a trigger, so we can search the literature ourselves on the internet, YouTube, or etc. So we can from the public health video that you made, doctor.
Right, thank you. How do you feel with the experience?
Yeah, that was good. That was fantastic, doctor.
All right. So what about Dwi yourself?
Okay, thank you, doctor. I think it is my first time to do this method, doctor. But something that I learned is same as like Dita mentioned before. Maybe I will underline the type of this learning is about how to simplify explanation to the people. So as a non-medical people, maybe they are difficult to understand what we are trying to explain to them, and then the pathophysiology on but we can simplify through that. And for us, the clinician or the doctor, so we can learn much information through the simple explanation, and then we can elaborate and we can increase through the evidence base to get more information, and then we can get the important message for the disease through your video, because from this simplified video for public education, so we can see what is the main thing that we should know about this disease, because too many diseases that we are going to learn, but in this simple public education, so we can choose whether this is the information that is very important, and for us as a clinician and for the patient to get the information. Thank you, doctor.
Thank you. Reinhard, do you have anything?
Yes, doctor. I think the video that you shown, that trigger is a new method, and it's very interesting because I think it's currently up to date with the current information that we usually see and young people usually see in social media and in the internet. So I think it makes it easier to find the points that, and to understand the language that we and find points that we want to search and we want to study further in other references, doctor.
Okay, thank you. One last question. Do you want to repeat the technique with the next occasion? Because we meet weekly.
Sure, doctor.
Oh, wow, it's not a must, but you respond with sure. Are you being forced?
No, of course not.
Okay, so the next chance, I would welcome any of you pick different topics, okay? And then present it in in a faster way of presentations. Just pick the point and get it faster so that we learn more topics rather than these initiations with only one topic. We dissect every point. Okay?
All right, doc.
Right, doctor.
Yeah. So see you around, and make sure that you take care. For Reynard, hopefully that you get well soon.
Okay, doctor.
Yeah. See you around. You take care.
Thank you, doctor.
Thank you. Bye.
Bye,
Bye,
doctor.
doc.